Hello, my name is Nick O'Shea and I'm the Chief Economist at Centre for Mental Health. Today we're putting onto film a whistle-stop guide to this, which is Economic Theories of Public Service Provision, Part 2. And this is a document really that has 5 topic areas that we're going to look at, and it's been funded through the Mental Health Economics Collaboration, which is a team of ourselves, the London School of Economics, and the Mental Health Network, which is part of the NHS Confederation. So Chapter 1 is about how we measure effectively the success of a mental health care system. In this case, an emergency mental health care system. So here it is. So someone will come in with an issue or a problem. They'll be assessed. If they then go on, they might need treatment, this class. And then once they've had treatment, they'll either be successfully discharged or things may not go to plan, and then they may come back into the system through a readmission or other way. So a basic system. There's been a lot of talk around, do we actually focus on this area? So saying, how long does someone wait in an emergency department to be seen? So is it 4 hours? How many of those people get seen in that time? So what we do in this case is we say, here are these people coming in, using a high street brand of sweets, and then how long does it take them really to leave the packet and go into this assessment glass? But then actually, once they're in that assessment glass, there's then another wait before they'll then get treatment. So we're very interested in this bit here is how long does it take these people, presuming they all need treatment, to go into this glass and get treatment? So how long does this bit begin to take? There's then some more of what we call stop time, is a manufacturing term. It relates to the amount of time a thing that's being produced sort of stops and isn't being produced in that moment. It's just sort of stopped because you're waiting for a part or you're waiting for something to happen. So there's this sort of stoppage time here between treatment. So it might be between appointments, it might be getting another referral to a different service, but actually the gap between these two things is then very interesting for us economists because it's about how long that's taken really impacts on the people in this glass. So then they come through to successful discharge, hopefully, and some will go through to a less successful one, so they're quite noisy. And again, people then start to flow through here, and then they flow through here. Now the problem with focusing on this bit is that actually you can get to a point where, yes, everybody's coming into this system within 4 hours, but unfortunately nobody's really leaving it. And so then what you end up with is a bit of a mess. So again, it's trying to look at the whole system and say, how long is it taking between each one? Now, for those who need a kind of radio headline for people to be able to hear, how well is my service doing, I would say it's actually less about this and much more actually about this. How long does it take someone to go from here to a successful discharge having had great treatment? So that for us economists is really the measure. If we can get it all in, fantastic. If we have to pick one, it's that one. Chapter 2 is all about the postcode lottery. We hear a lot about this, and it's about people getting differential outcomes depending on where they live. There are 2 parts to this equation. What goes in, so your local income, and what goes out, so local spending. Now, on the income, that is determined nationally through a complex series of formulas. But in short, there's a needs assessment, might be several years old, that looks at the sort of population of your local area. There's then a how much do you get in comparison to other areas, so there's a sort of comparative part of it. There's then how much progress are you making in terms of getting to your goal. And then finally, there are specific factors relating to local areas like pensions. So these things are sort of quite difficult when you bring them together to get a homogeneous amount that goes to a per person, per capita spend. On the expenditure side, there's then been a big change over the last 10 or 15 years, which has moved towards local areas being able to spend what they think is the right things to buy. So people being able to say at a local level, okay, this is what I think we ought to have in terms of services. But again, people may not prioritise the same thing, may not prioritise the same services, and the result is a difference in the services that are on offer. So differences coming in, differences coming out. How do you resolve that? I think there's probably a very simple way, which is to just have one obvious metric, and that is life expectancy. So where my parents live, if they turn left and go half a mile, or they turn right and go half a mile, the difference in life expectancy between those 2 populations is 15 years. And I think actually saying the per capita amount may not be that important, but the how long you live estimate would be a great way of making sure that we get the right outcomes for the right money. Chapter 3 is about cost-shunting and fractured markets, which is something we discussed in part 1 of this series. And really what I wanted to do here is it's not the most easy chapter to read. So I was just going to very briefly give an overview of how people in finance areas and offices decide how to cut services. So just the economic reasoning about why you might decide to cut a service. So there are basically what's called scenario models. And this is where you take your best guess at what are the three most likely things to happen. So say I'm thinking about cutting a service that will lead to these three scenarios. Scenario one is, okay, the people that lose their service then actually deteriorate quite quickly in terms of health, so they end up using more costly services, which I also pay for. They come out of my budget. So that's bad because my costs have increased as a result of my decision. Scenario two is where the same people again experience a decline in health or outcomes because your service has been taken away. But what they do is they go and seek support elsewhere. So services provided by other people, different budgets, nothing to do with me. So in that example, I save money because I've cut my service, but actually the people have gone and sought help from somebody else. That's scenario two. And then scenario three is where what you presume happens is that the people that you that had the service, that have had it removed, actually they're just fine. So they go on about their lives and their outcomes don't change because actually the service you're offering made no difference at all. And what you end up doing as an economist or as a finance officer is to sit there and say, what is it that I think is going to be the mix of these three scenarios? Because some I will save money, and some I will not, and some the others will pay. So it's about looking at the three and the ratio that you think is the most likely of those three coming together, and then the number you get at the end. That essentially is how you do an investment case when looking at whether to expand, shut, or change a service. And so what that means for mental health services is that actually when you're thinking about the economics of what you're providing, it's being very sure that you can show that in the absence of your service, the increase in service need that may occur is substantiated. So you can say need will definitely go up in the absence of this service. Here are the outcomes, part one. And part two is that we will pay the bill because the most likely services these people will use are just other services that we offer. So it's demonstrating that need and that it's not going to go away, and demonstrating that that need will have to be sorted out within the same budget heading as your service is now. Chapter 4 is about online provision of mental health care and support. Now, online activity is really important. It's the future, but much more essentially, it's the present. And actually, there are a lot of portals now and different ways of engaging with online mental health care. And I think there are several advantages and several disadvantages, and I'm going to outline 5 of them now. So the pros are demand mapping. So at the minute, a lot of mental health services which are provided in society use needs assessments that may be 5 or 6 years old. They're then in turn using data that's 3 or 4 years old. So actually what you've got there are services based on assessments which predate things like smartphones. So we know the impact that's having on people's mental well-being, but actually a lot of those strategies don't encompass it. However, if you've got an online site or portal, you've got that ability to map demand in real time. So when people come into your service online, what are the things they're looking at? Is it about topics such as self-harm? Is it about eating? Is it about body image? What are the things? And you can very quickly understand what are the rising issues. That's a very powerful advantage to this service. Secondly is economies of scale. Again, we covered this in part 1, but it's the idea of as you expand something, the average cost of provision falls because a lot of your costs are fixed. So again, with this, you pump a lot of money into the actual the hardware, I think it's called, to make sure that you've got your site. But actually, once you've done that, your variable costs aren't too bad. So whether you're providing it to 1,000 people or 1 million people, actually those fixed costs that you spent at the beginning will just be divided by more and more people. And then finally, the ability to use resources flexibly. So if your service offers online Skype counselling, for example, you can provide that at 2 o'clock in the morning very easily by just having someone Skype in from Australia or a different time zone. So you're not incurring those extra costs, those sort of overtime, nighttime provisions, and you're able to offer a really flexible service that, again, responds to that demand. Challenge number 1 is measurement of success, and we need to get a lot smarter and quicker at how we substantiate and evidence that these schemes, these portals, are actually working. So do we know what a young person's need is when they're coming in? Do we know what happens during the duration of it? And objectively, do we know what happens at the end? And I think at the moment there just isn't that information, particularly looking at the system-wide impact of how these portals affect things. So actually, is it that referrals to community mental health teams for children and adolescents are falling as a result of the implementation of an online portal. So this kind of data. And secondly, I think as commissioners move from having a digital offer to the best online offer, it's very much about areas working together, because data is all about size. So the bigger your sample, the more accurate your outcomes measurements are. So it's about collaborating in probably quite a new way to get the data between areas so you can benchmark and say, well, okay, we're getting this, we're getting that, what are you getting? And again, the bigger your sample, the better. And then finally, the last challenge is very much around gaming the system. So because you've got these flexible resources, you can move them around between areas. So again, it's this ability about how you're measuring what's going on at a given time. Because if someone meets their annual criteria for success in month 6, there's actually nothing really to stop them from a technical perspective in just moving those resources to another area, because we've met our targets in Lewisham, and so we're going to move them to Bromley. So it's about making sure that there's those gaming the system opportunities are removed. And that is my synopsis of online care. And then chapter 5 is our final chapter. So lastly, but quickly, this is really just saying presentation matters. And the two things that you can do to make your presentation matter is, one, make it accessible to people by using things that they will find useful. So here, for example, if you find colour charts useful, this is a great way of actually just looking at this and saying, lots of this is green, this bit's red, here's probably the problem. Although you do have to remember that 10% of men are red-green colourblind. But alternatively, you can use infographics, or you can just use data that actually people are interested in. So for example, how much is a prescription spend in a GP surgery per month? Actually, those are the kinds of things that for physicians are just really interesting to compare, to look at and to examine. You don't need to necessarily draw any conclusions from it, but actually it's the kind of data that makes people engaged. So make it easy for people to look at it and understand it. Make it easy because it's relevant to them and it helps them do their job better. And that's it. So I hope you've enjoyed this. I hope it's been quick but thorough, because that's what we've aimed for. And if you've got any questions, please contact the head office at Centre for Mental Health.